Good afternoon, everybody. Thank you for coming, showing interest in my. Showing interest in my work. I want to believe you're interested. That's why you're here. Am I correct? Absolutely. Okay, so thank you for coming. My name is Idriss. Kallon. I'm coming from West Africa, Sierra Leone. For those of you who don't know me, I've been in South Africa for the past 11 years. We're permanently residing here with my family. I have 3 children. I also have another family here. Chris is my stepdad, and I'm just joking. He was my supervisor, and I'm still working with him in this, in the School of Division of Social and Behavioral Sciences, not School of Public Health, of course, in School of Public Health. I'm working on a TB project. It's an interdisciplinary project on infection control. I have some of my colleagues here working on that project. Welcome, Sanj. The title of my research is called Influences on the Continuity of Care for Patients with Tuberculosis, Mycobacterium tuberculosis, referred from tertiary and district hospitals. The key term there, continuity of care, I'll talk about that later. I developed this concept. I'm going to actually browse through a lot of the background and the aims, but of course you have to get the aims and objectives, significance of the study, but I'm going to rush through these slides because I believe when we're going to have interaction, questions, comments, we'll come back to them if that's fine with you. I developed this concept when I was working as a data administrator at a hospital. I refuse to call the name because it's one of the hospitals where I recruited some of the participants. I was working there as data administrator. I was involved in a larger study that was looking at continuity of care, but they were drawing on mostly healthcare workers' perspective of this concept, which I'm going to explain in a moment. So I thought that I was asking myself the question because I was a research assistant, we were doing the interviews amongst healthcare workers, but I wasn't actually getting anything with regards to the patients themselves, who are the ones who are infected with TB. And I thought that social determinants of health, these things started actually coming to mind because I'm coming from a sociology background. Not only that, I've been involved in work with patients in different areas in my country before coming here. So I've been interested in health research for quite a long time. HIV/AIDS, and now moving to tuberculosis and infection control, which is also linked to TB. So I thought the patient's perspectives were equally important, and also their lived reality, to bring that to the fore. So the general background, I want to believe some of you already know, there's high incidence of TB, and that accounts for about 8.4% of all natural deaths. South Africa has also a triple burden of infectious diseases. That's TB, multi-drug resistant TB, and HIV. So that's the general background. There have been improvements in the health system. Probably some of you will know that as well. It's a shift from the apartheid racialized past to equal health service delivery for all. But there are many challenges remaining. These are just few, small number of healthcare workers given the high number of TB cases, and also high level of poverty among people mostly infected with TB. So that's the general background. But the specific problem that I looked at, there were many patients looking at doing the interviews in this research project that I mentioned earlier, and also I've been looking at TB data in the hospital. We noticed that there are a high number of patients who drop out after having been diagnosed in the hospital to continue with their treatments to primary healthcare. But some of the studies that have been done on this topic, they've looked at the patients who have attended or not attended when they've been diagnosed at the hospital to continue with their treatment to primary healthcare. And as I mentioned earlier, these studies have drawn mostly on healthcare workers' perspective, and I wanted to look at the patient's perspective. So the aim of the research was to analyze factors that influence the continuity of care, patients moving from the tertiary or district level hospital to the primary healthcare clinics. The questions I was asking, the main one was what factors were shaping patients' attendance at primary care clinics following TB diagnosis and start of treatment in the hospitals. Some of these sub-questions were, how did patients diagnosed with TB interpret and act upon their diagnosis and treatment at the hospital? What roles they played in this discharge process? What were their home circumstances and experiences at the clinics they were referred to regarding their registration and follow-up plan? What were the patient's perceptions of what influences their attendance or non-attendance? And what were the perceptions of healthcare workers and policymakers of what influences patients' attendance or non-attendance at clinics? The objectives were quite straightforward: to contribute to our understanding of patients' experiences and perceptions of TB treatment, to inform policy on how services to patients can be improved to enhance better continuity of care. So as a concept, it has been used in two major ways. The first one mostly coming from Global North. There are lots of materials on that. Their definition of continuity of care is a patient going to the same physician over time. They are corporately involved in this ongoing healthcare management. So it was operationalized by evaluating the times that patients saw the same physician over time, and also this prolonged relationship that correlates with the trust that they have in the physician. Because if they keep on going to the same physician over time, and that's the way they looked at it. So the second way, mostly from the Global South, and there are a few materials around that, they evaluated continuity of care on the interaction with the health professional. It includes trust, but not with the same professional over time. Okay, and that includes the referral of patients and transfer of information between two health centers. So I used the second way. The rationale for using that, the pattern of treatment designed for TB patients diagnosed in hospitals was to start their treatment in the tertiary care. Of course, there are different health professionals there, and when they are referred, they are also going to interact with different sets of health professionals. So it just makes sense to use the second way of continuity of care. Also, the patient's treatment had a set time frame, and which was 6 months for drug susceptible TB and about 18 months to 2 years for the treatment of MDR. So what am I bringing to this big chunk of literature out there? Well, the second connotation of COC, continuity of care, if I say COC, that's what I mean. The materials were not a lot. I used the concept in the context of referrals, patients moving from one health center to the other, the transfer of information between two health centers, and also patients' experiences of treatment in both health centers. So my research was not only limited to activities in the hospital and clinics, but also including the patient's lived experiences at home. In other words, I acknowledge that failures of the health system can impact patients' continuity of care as much as their socioeconomic circumstances. So I brought in the home and community context into the COC model. Significance of the study. So far, attention has been paid to patients being referred up. That is from, example from community clinic to hospital, rather than those referred down. That is those diagnosed during inpatient care and referred to local clinics. This study reveals both patient-specific factors, health system factors that can shape COC and help inform service provision and the wider public health policy for TB in South Africa. I also brought in a different kind of, it's mostly ethnographic, which I'm going to explain in a moment, following the patients from their diagnosis at the hospital, they're going to the clinics, and also their home circumstances. So I actually got interaction with these patients from the 3 layers that I've just mentioned. The theories that I came up with, we actually had social determinants of health, because we don't go to do research in the field as if we don't know anything about what has been done before. So we had social determinants of health, mainly because of the kinds of patients that we were looking at. They were coming from poorer backgrounds, and so we looked at poverty. Most of the patients that were infected with TB are coming from poorer backgrounds. We also looked at Foucault's concept of the medical gaze. That was before data collection. And his analysis of that is that patients should be seen as partners in the treatment process rather than an object of treatment. We also, then after data collection, we brought in the aspect of patient-centered care. Because I think you cannot talk a lot about patient-centered care if you don't listen to what the patients are saying. So it's consistent in the literature that even though they have a lot of differences, explaining this concept, but what has been consistent in the literature is that the patient is the center of focus. It's not a doctor-specific concept. It's not a technology-specific or related concept. It's a patient-related concept. So you can see the diagram there, continuity care. These are the three theories that we use to explain the findings. It's a qualitative case study. We looked at patients in the two hospitals, one tertiary and one district, and the clinics. We only chose these clinics because these were the clinics that the patients were referred to. They were not chosen before. Methods, we use a purposive sampling, inclusion criteria were patients who were diagnosed with TB, while in hospital, some of them, we followed two that were co-infected, HIV and also drug-resistant TB. Health workers who dealt with the patients, policymakers who understood the treatment of patients at the hospital, and also the concept. All patients were adults. We only stopped recruiting patients when we were not getting new information. That's what we refer to as theoretical saturation. Some of you might know that. We selected these hospitals because they diagnose, treat, and refer patients to primary healthcare. And we focused on medicals because we cannot follow patients all over the hospital. We chose one specialty where we know there's high cases of TB, the medical specialty. So in the two hospitals, those are the words that we focused. Yeah, sorry. So we got to identify the patients based, and we got their names from the hospital registers and their, of course, medical profile. We made sure that these were patients that were diagnosed within the hospital. As I was working there, I also built networks of health workers who referred me to potential participants. So in total, we had 54 people who participated in the study, 17 patients, 6 family members, policymakers as well, 10 healthcare workers in hospitals, 19 in clinics, and 2 policymakers. Well, I've already mentioned that. The breakdown of these 10 healthcare workers, you can see them there, combination of nurses, doctors, social workers. We had nurses, community health workers in the clinics, TB counselors, social workers, and doctors. So of the patients that were interviewed, 10 were additionally added. Those who were discharged after hospital that we followed. 1 passed on before the completion of treatment. 2 were diagnosed with their drug-resistant TB, who were expected to complete their treatment within 18 to 24 months. So we did a total of 62 semi-structured individual interviews, 3 focus group discussions between October 2015 and February 2017. Observations were also done throughout all of these phases. You want me to stay longer on this, or should I just? Okay. So how we assess trustworthiness of the data, we were constantly evaluating what we brought to the research space, language, background. Some people say I speak funny, my accent, the way I look. So some of these things you have to be aware of them when you're speaking to people. The reason why sometimes they have information that can help you, but they just withhold information based off the way they see you, and they sometimes don't know what you're there for. So I have my able assistant researcher who was versed in the local languages that these people speak. And so we constantly evaluated that. There are times when I will lead in the interview. There are times when I will allow my assistant researcher to lead. So we evaluated language, knowledge, gender, ethnicity, all of these things we were evaluating as we go along as a sense of reflexivity. We had multiple encounters with the patients. We met them at the hospital, clinic, and we went to their homes. We built relationship over time. And some of the responses that we got, it was only the third important responses actually, I would say. I don't think if I'm right to say they were important or not, based on the patient's perspective. But what I'm trying to say is that certain piece of information we only got after the third interview. And these were very important. And it came out of this prolonged engagement with the patients. Yeah, so we created an atmosphere where patients would be comfortable to respond to questions, assuring them of confidentiality throughout the interview phase. We don't only explain that aspect once. We say, okay, well, we've got the ethical aspect out of the way. We constantly go to that. We allow them to speak in their own language, as I said earlier, for them to feel very comfortable. We analyze the data using My's approach to qualitative data analysis. These were three interwoven components of this approach: data reduction, data display, verifying conclusion. I'll come back to these, as I said earlier. But it involves, if I should just say briefly, reading and editing, segmenting the data, coding and doing memoing, finding themes, clusters, and patterns, constantly comparing the data. It's similar to other qualitative approaches, but what is unique about My's and Hoberman's approach, you allow the data to speak for themselves, and you create a tree, you create a way for people to clearly see how you cluster them in the patterns that you've made, and obviously that brings you now to draw a conclusion. I think it's easier to explain to people when you have a rich data display, which I'm going to spend a lot of time on. We got ethics clearance from all bodies that we worked with, UCP, the Western Cape Province. I just want to pause here a little bit to wait a while, because I submitted the first protocol to the sociology department. To get ethics clearance was really a hassle. Thank God I moved over here. And we had a good relationship and also how to go about certain things. But health research, I warn all of those who are involved in it, ethics application can be a nightmare. So we had to apply to all of these institutions to get access. We assured the participants of anonymity, and we informed them about their obligations and the risk involved in disseminating information. In the focus group interviews, obviously, there are more than one people, so you cannot say confidentiality is there. But we told them that they should not discuss what we have discussed here with other people. But you never know if that's going to be upheld or not. But we explained the ethical implications. We did not give anyone any money, but anyone that used their own money to come to a place where we have to interview them, we had to reimburse them. And we provided light food, refreshments, and drinks for every interview. We also protected ourselves when we go into these spaces. We were using our N95 masks, especially the interviews in the hospital and the clinics. It's only when they've been declared that they cannot transfer the disease that we could interview them without wearing an N95 mask. But even at that, we had positions that we will sit to protect ourselves, opening windows, so on and so forth. We identified the participants by a coding system, and we use pseudonyms mostly. You will see how we do that in the data display. Okay, I'll just skip all this. Okay, so coming to the findings, these are the patients that we followed. These are their pseudonyms, their sex, age, the highest education completed, their race, mother tongue, marital status, if they had children or not. This was important because, for instance, there are some cases of FDR. So we also evaluated their family status and if they were employed or not. So the average age of the group that we followed was 35. Their schooling completed was grade 10. 11 of the participants classified themselves as Black, African, and 5 of them as colored. All the Black African participants spoke Xhosa as their first language, while the colored group spoke Afrikaans. However, all of them communicated well in English. Only 2 of the patients were married, 11 had children, and 12 of them were unemployed. Okay, so these are, no, sorry, I think I made a mistake in the previous slide. These were all the patients that we interviewed, that we recruited in this study. These were the ones that we followed up, okay? So we interviewed this in the hospital, the previous slide, and these are the ones that we followed up. And I put in here the ones that it did not complete. Now, this study, as you've been hearing, it wasn't about adherence, but adherence is included in attendance, okay? The linkages, and I explained what continuity of care meant. So but of course, yeah, so attendance, we looked at attendance, but we also evaluated their completion of treatment. Okay, let me come to the findings now. Can somebody tell me the time? I've switched off my phone. What's the time now?
12:23.
12:23.
20 minutes.
I have 20 minutes more before questions. Okay, thanks. All right, so we I numbered the findings. They are not like we had 30 findings, but just to put a figure there. So if you you want to come back to some of these tips, I can easily find them. Okay, I'm not as young as some of you are. With all due respect to those who are over 40. All right. So inadequate health promotion in the context of patients' TB education. This is what one of the nurses said. PN there is professional nurse. So if you see that, the allocations, I will explain them as I go along. We don't always speak to patients, but at times we will speak to the patients if they know about the results. We do not have a structured program to train or educate TB patients. We have a structured program to train our staff. And this is also from another nurse. She said, if we have enough time, yes. I have the booklet. We try to teach the nurses to give the patients the booklet. We have, tell them in their own language, this is how the lungs look, but we cannot do all of that. We have too little people. So what we see here is that patients are diagnosed with a disease that they have to continue with. They have to go to the next layer of treatment, but they don't have sufficient information about it. That's one of our findings. And this, as I go along, I think I'll talk about some of the theoretical frame where we are coming from to explain some of these, as I said. So patient-centered care, as I said earlier, we were able to bring that to the model because of what the patients are saying and what, of course, the staff members are saying about education. Because we know from the literature that patient-centered care has to do not only with the treatment of the patient, but the person of the patient. Because if you are not looking at the patient enough and evaluating their feelings and know what they understand about certain things, they can leave that space and they will come back again with a difficult form of infection, which is like MDR. You get what I'm saying? All complications of the disease. So that's what we find out. And we also spoke to some policymakers, and these are some of the things that they were saying. And when I say policymakers, are not like those who are only drafting policies, but those who are implementing policies, another layer. Now let's give some attention to the alma mater declaration. You note with post-94, after apartheid, all of a sudden you realize that but your TB patients are ignorant about the disease. This is somebody who has worked in that space for over 20 years. She's worked in clinics, hospitals. She's at a position where she's giving her analysis about what has been happening so far. You give your tablets End of discussion. About 22 years later, I still see that we are still neglecting educating the patient around the disease. And even with the HIV, where HIV management started with education of the patients, and you can see the difference. Education should happen everywhere. We also realized that there was more focus on the patient's treatments while having to take in your drugs and why you here again, but failing to realize that there are other barriers to this that haven't been actually discussed. There are no conversation around that. And I think that education should not be disease-focused assumptions. We are not asking the patient, what do you know? What do you feel? What are your fears? What is your challenge? We are not asking, we are assuming we know it. So we respond to our own assumptions. For example, with the adherence counseling, for you, if you look at the content of the training for an adherence counselor, it is not bridging the gap between the nurse or doctor and the patients. We are just creating another layer or level of nurse-doctor to talk to the patients. So we are not addressing the patient's needs. We also saw some sense of hopelessness based on what the patient was saying. This is what Apiwe is saying. By the way, these are synonyms, okay? They're not the real names of the people. No, they will not ask how you feel. So in other words, patients, they are looking forward to that. It's not like when they come to a space, they just come for like the program that you've set. This, it's a medical program that you must do A, B, C, and D before you go. So they understand that you have to do all of these, but they also understand that they need to be asked about certain things. And so Apiwe is saying that they will not ask you how you feel. There's nothing they are going to share with you like lesson. There's nothing. They are just treating here with medicine. So he is also not oblivious of the fact of this medical structured system in the hospital. And when I saw the tablets that I'm drinking here tonight, I saw they expired in October 2015, so I don't know whether it is that tablet that affected me. So the patient even discovered that at that particular time, the drugs that he was taking for his legs, he had some problem with his legs, and he saw that the drugs were. So I asked him further, I did not actually get that. If he explained to the nurse, she said, no, he didn't. Because there was only nurse who would actually even ask him, who would even engage in a conversation with him. So he realized that there was something wrong, even with the treatment that he was receiving, but he didn't have the space to articulate that. Bianca, this is an interesting quote, and I put there, Bianca, by the way, was the one that passed on, one of the patients that passed on. She said, what can they do now about my stomach? All they can do is to give me my tablets. Yes, they cannot do anything now. I can just lie here. All the doctors have done everything for me. So I can just lie here for nothing. And in as much as, she could understand that the doctors have done everything for her, but she is still alive. She is still alive, okay? She needs to take the treatment. And we've seen patients who have their CD4 count very, very low with proper management, proper care. The CD4 counts, they shoot up and they leave, okay? They leave. But unfortunately, Bianca passed away. And I'll explain the discharge process, some of the communication that happened between the patients and the doctors and nurses before they left the space, and how they internalized this information before they left. And also what added some complication to this transfer of information, or even understanding what they've been told at the hospital to get to the other layer. The socioeconomic circumstances, as I mentioned earlier, to bring into this continuity of care model complicated the whole issue. Because now this Bianca lady had problems with her mother. She could not go there, but she ended up at the house of the mother in a one-bedroom apartment. And the mother was constantly complaining that she was not expecting her to just pop up there. So she was complaining about the process. How did she get there in the first place? Because I didn't give her my address. And there was this estranged relationship between Bianca and the mother. And the next is, I'll get to that in a moment. So This is Caitlin. Sometimes I feel Caitlin's voice cracks. This is another patient who had a lot of things to say about her home circumstances, about even the pills themselves that she was taking. I drink all 7 pills. If I take my pills if I drink all of my pills, I will die. This is what she was saying. I drink it the whole day, but it's finished now. Yes, it's all right. It's my skin. I cannot even buy lotion. She was just going all over the place. But what she was touching on were things that were really, really affecting her. So she was not only particular about her getting treatment, but the way she was feeling about her home situation that translated to where she's at now at the hospital. So these patients, of course, are not coming from a vacuum. They are coming from a place where they have issues that they are facing. So she said she felt very depressed. But what are some of the problems behind that? Not having time with the patients, not sitting the patients down, and who should do that is also complicated. We'll get to some of the responses in a moment. Matilda is saying that they should get more staff. So we've seen that the workload of the healthcare of the doctors and the nurses is one of the problems. I think I'll have to run through some of these slides because of time. Yeah, this is also about workload. They also mentioned the cultural differences. So they thought that why should I actually speak to somebody that could not really understand what I was saying? But I want to believe there are other staff members who, they mentioned that there are staff members who could understand the language of some of the patients. Yeah, so this is a challenge, cultural and linguistic differences. No, it doesn't, my role doesn't. That is like, my role doesn't involve teaching. I often say a little bit to the patients. The problem is for doctors, they don't really have time to sit down, which I've mentioned earlier. And she also mentioned, and which ties up with what the policy maker said, there's a great assumption that everybody in Kallon knows about TB because it's so common. And also there are lots of cultural issues, which I've mentioned earlier. Okay, this is another. We also drew on what the patients knew before they come to the space, because that's another factor. This is my conversation with Bukle, Bongani, and Apiwe. Say we don't know whether it's a treatment or it's my body. She's confused. She doesn't know anything about TB. Bongani said, I don't know, I'm confused. I know nothing about TB. It's the first time I've heard about TB. Now, let me just pause there. What they're trying to say doesn't necessarily mean that they haven't seen somebody with TB, or it's probably the fear speaking. They might have heard about it, but the fear is also mixed with that. But I'll get to a point where, yeah, in fact, Bongani said it, I was always afraid to have TB. So you cannot tell me that I don't know anything about TB, then you say I was afraid. You get what I'm saying? So it's like they know about TB, but they don't have sufficient information to allay that fear. They don't have enough interaction to allay that fear. So that's why I put that other line there, that I was afraid of having TB. Yeah. Patient's involvement in discharge planning. Now, this is not, we can read this, but what is not said is what we do on, because our analysis, what informed our analysis, not what was said, but what was also missing. When we discharge patients, we obviously give them a form, and there is also a specific TB referral form. So this is now the case of normal TB. We usually use the first 2 weeks in the first month of therapy, and I must admit from the clinic, we do not follow up. It becomes the responsibility of the clinic. So you can even see the delinker there, but usually they do keep an eye. But that's what they should be doing, obviously, for the inpatient admission, like MDR, etc. The doctors, they do follow up. You are taking up home-based carers. That's only the sisters that will do the follow-up. They usually refer to the doctor. So you always hear the patient needs more attention. Now, the patient is not being included in this discussion at all. And their involvement, said in both hospitals, the roles of healthcare workers in treating patients leading to discharge planning or lack of did not include what the patient had to say with regards to their home setting. Because when you're discharging somebody, there are certain things you must, I think, know. Does the patient really understand where to go next? Does the patient really understand, the disease, okay, that has been, mind you, they were diagnosed at the hospital, not from the clinic coming to the hospital. Okay. Yeah, so do they know the next layer, and do they understand what lies ahead after discharge? Okay, these are some of the needs. The patient spoke about the things that they need: transportation, food, and money. These are all what these quotes are saying. I just want to bring out. Okay. Now, let me transition to the home setting, because I said, I cannot finish this presentation if I don't talk about socio-economic circumstances. Now, so in my second and third interview with the patients, when they are home now, I asked Fezeka, how have you been feeling? Feeling better? Though I'm not working now because of my illness, work status comes there again. But sometimes you get pain, like vomiting, that gets more support from the hospital. And I said, what makes you say that? Because always the nurses at the clinic will give me the tablets and everything and say, you must eat now and take the tablets. The tablets caused the death of my daughter. I paused there when she said that. So I said, okay, how do you feel when you have to take the same treatment that you say caused the death of your daughter? I didn't feel good. I'm always vomiting, I'm not eating. Another doctor took me to another hospital, another clinic, eye hospital too. And they told me that my liver is damaged, and my brother, he was so upset. I was also upset. He wanted to go to the doctor, asking why he gave me the tablet, because my liver was damaged. I'm scared. I'm so scared. And I said, what did you do after this? I stopped going there and stopped taking the drugs at the same point. This is the patient that I said it was only the third interview she revealed this. Okay. And because I've been sitting with her family members, we've been having chats, and she came through. And she stopped between 4 to 20 weeks, because I checked the time when I conducted the last set of interviews. So I said, okay, did you stop going to the clinic to receive the drugs at the time that you were scared? She said, yes. I went to that doctor on Monday and asked him, why didn't you tell me that my liver was damaged? He said, no, it's not me. It was the nurse who gave you the tablets. Why didn't you tell me? So there was this misinformation and blame game happening. So Apiwe also mentioned something about, so he was scared, he was confused. The previous lady was scared. He was confused about the treatment. He was the patient that actually demonstrated some knowledge of TB. So he was constantly asking what kind of TB he had. And this wasn't said. So he will leave the hospital saying that, okay, you have something that is somewhat like an MDR. That was it. Okay, wow. Okay, somewhat like an MDR, but not really MDR. And so he left the space confused, and he had to stop the treatment because of that. Okay? Yeah, so this strange relationship, I've explained it before, so the data actually refer into that. I thought I would be able to do this in 30 minutes. I was fooling myself. Okay. I was so excited with the quotes, and there are lots of things to say. Sorry. Okay, there are evidence of stigma, feeling embarrassed at clinics. These are all things that tied up with the literature. Stigma at home. Idriss was discriminated against by her own husband. These are things that we normally talk about in the community. Will this happen at home? I think it also has some resonance with HIV study. Domestic abuse. Nandipa was actually abused. Her uncle raped her, and that's where she contracted the disease. HIV. And then when her uncle came again, the same house when she was accessing treatment for TB, her whole life just stopped. At that moment, she could not continue with her treatment. She could not go to the clinic anymore. But interestingly, what we did, we looked at some of the data at the hospital, at the clinic. So if patients said, no, we stopped going there, we had to actually cross-reference the information. You get what I'm saying? To actually know that it was true or not. So that's what we did. And those who attended the clinics, they had good family support, and they had enough income. There are evidence of that, all from these quotes. I can send the slides to whosoever need them. I don't know what I was thinking. Okay, we had a lot of stuff. Inadequate education, the clinics, so the patient-centered, lack of patient-centered care also happened there. So the major discussion points, I think I should just run through that quickly before you ask questions. Patient-centered care was lacking in both health centers. PCC allows the patient to explain what they understood and ways that the treatment could be better. Educational counseling patients should be a time when patients should be given the space to express their concerns, their fears, their anxieties, which could enhance PCC, and how they internalize the diagnosis as well. How they understand the treatment, it leads to if they don't understand, it leads to misunderstanding of information by doctors and nurses, and feelings of hopelessness, powerlessness, and confusion were what we saw. Okay, I think I'll just skip all of this. But I can identify some limitations to the research, or rather, as you talk about them, the perception of my role as a researcher. One of the patients called me doctor. So it's possible that some of these that actually continue with their treatment thought that I was there to monitor them. So, and the interviews in the hospitals, these approximate spaces that we spoke to some of the patients. We tried actually to speak softly and maintain some sort of distance between ourselves, and some of them were moving about, so they were able to move far away from the rest of the other patients. But the MDR patients, or rather MDR suspect patients, were interviewed in separate spaces. Areas of further research that were identified, I think there should be some sort of in-depth exploration about the reasons why they arrive at the hospitals in the first place, because primary health care is the cornerstone of public health policy. And we also thought that exploring the understanding of dots, there were some quotes that I skipped where the patients thought that the community health workers were coming to spy on them. So they saw them as somebody checking on them, not really helping them. Okay, which the dot system is really promoting. So we say there should be clear policy statements on education, who does the education at the hospital, that is like where they are diagnosed. Being proactive in patient-centered care, addressing the social determinants of health. This one is actually ambitious recommendation, but we have to put it there because we saw some patients that we described in the thesis, the background and the setting where these patients are coming from. Because you can treat a patient and you send the patient to the same living conditions and come back and treat the same patient again. So where are we going? We have to revisit the DOT strategy because, as I said, the community health workers are an integral part of the DOT strategy. But some of these patients saw them in a different way. So let's go back and see. So you can see the references. I can't list them here, otherwise I'll have another 15 slides. And I want to thank Chris for supervising me and keeping up with my bad language writing. Oh my goodness, the editing was a nightmare. And Megan, I'm telling you, English is such a, anyway, let me leave that conversation for another day. The funding that I got from the division, Lillian Dudley was the lead investigator in that larger study. We've actually submitted now to, I think, +1. We are doing editing now to publish. Frederick, Judith, these were my former supervisor when I submitted the protocol to the sociology department. My family, my beautiful wife and kids. Even if you don't say she's beautiful, she is. Kumsile, my research assistant. The research participants, and also Elizabeth Lutz, who proofread my thesis. Thank you so much. Yes, any questions, comments? Exhausting. Yes.
I have a question regarding thank you so much for the presentation. It was wonderful. I'm very happy that I finally really know more about your work.
Yes.
To start with that.
Yeah.
My question was kind of around the barriers of wearing a mask.
Yeah.
As a researcher, which I think is a very important part of for the ethical considerations and reflexivity. So if you have a little bit of time, then I would love to hear a little bit about your experience of interacting with patients whilst wearing a mask.
Yeah.
I know there's a lot of stigma.
Yeah. And it is interestingly, the time I did the research, it's only now that I have, adequate information, probably not too adequate, but at least sufficient information about the N95 mask. The time that I used it, firstly, I didn't even do a mask fit test at all. And then I realized later on that the mask that I was using was even bigger. So I was going to those spaces, not really, I had a false sense of security. But to answer your question, at that time, I didn't really thought about the barriers at all. But thank God when I interviewed the patient when they'd been discharged, we did not use the N95. Probably that lessened the sort of barrier, because we've heard now that it can create a barrier between yourself and the patient. However, we can also make it common by the way we use them. So if patients use their surgical mask and we use our N95, when I say we, it's like, all health workers, it will probably be a common thing, and that barrier will be probably minimized.
Yeah, you're talking about ways of promoting.
Yes, ways of promoting. Yes, because 95% it has been proven that it protects you from infection. So you don't want to be helping patients and you yourself at risk. You get what I'm saying? Not only as a researcher, I'm not coming from a point of researcher, but also healthcare worker, working there 24 hours. Yeah, not 24 hours actually, but 7 days. Yes.
Thank you.
Thank you. That was just fabulous, and you clearly, you've collected such a huge amount of data. And I think the question that I'm sitting with kind of links back to the whole thing about continuity of care and including a patient's perspective on that. Did you get a sense from your patients about what like an ideal situation would be in terms of continuity of care and the relationship potentially between a more centralized versus decentralized model? Because of course we can't be keeping DRTB patients in facilities, but is that what they would rather have? And if so, like, what are we doing about that?
It's so unfortunate that I think that's a question for further study, because the patients that we interviewed, only 2 of them discovered their MDR status. In fact, they were not sure, as I projected, and they were really not sure. But I asked what their ideal situation would be. For instance, if they go to the clinics, and how do we want to be treated? There's a bunch of quotes that I didn't go through, where they were saying, firstly, the kinds of drugs that they receive from the hospital. Some of the healthcare workers at the clinics were complaining that they were giving them probably 2 months of drugs, and that affects the doc's plan, because you have to be monitored taking this medication after. You get what I'm saying? That's one. But for MDR cases, as I said earlier, unfortunately, we only spoke to 2 who were even confused about it. But we did ask that question, how they would love to be treated. And I think I projected one slide where the patient was comparing her treatment at the hospital and the clinics. They thought the hospital, the way they were treated at the hospital, apart from the lack of patient-centered care that I've explained, they thought that, I think it's in a confined place where they sleep and they give them their drugs timelessly, and they tell them what to do, and some of them might be able to ask some questions. So they thought the quality of service at the hospital was better than the clinic. But with regards to what they want to see as MDR-TB patients, we didn't get to that. I think that would be for a good further research question. Yeah. Yes.
Thanks. That's super interesting. I'm wondering, the one slide you showed of a doctor who talked about not explaining everything from how the medication works exactly to what TB is exactly, and all of that.
Yeah.
In that case, I think it was a female doctor, but in that case, it sounded like she basically considered it someone else's job, right? Whether or not that someone else exists is a separate question. But I know that also, speaking to my friend who works at a hospital in a similar setting, she's talked a lot about kind of assumptions on the part of healthcare workers about what patients will and won't understand, and kind of a lack of attention or effort involved in actually explaining what these things are, not just with TB, with so many different kinds of conditions. Cerebral palsy being the one that she talked about a lot. Like parents who've been caring for their children who are in their teens still don't actually have any understanding, because no one's ever explained it to them properly.
Yeah.
What it really means.
Yeah.
Sort of not from a crisis response perspective, but more like just for the person to actually understand what's going on.
Yeah.
So did you get a sense that it was more about like, okay, we're too busy, we don't really have the time to do this, or more about an assumption on the part of what the patient is capable of understanding?
Yeah, I think a little of both, because at some point they were saying that, look, we didn't have the time, which is one of the points, one of the reasons why they could not engage with patients more. And also they had assumptions about they know where, because these are patients that we see every day, come from Kailicha or Nyanga or wheresoever. And TB is high in those areas, so they understand. But that's a rude, I think it's very disrespectful assumption. I think that's really a bad assumption to make, because not everybody really understands. And one of the quotes that I projected, the patients, it's not like they haven't heard, but the fear actually overshadows that. So they just need clarity. They just need a little bit of engagement before they leave that space. Yeah. Yes.
Thank you for your presentation and dealing with a really important topic.
Yeah.
Just to pick up on the last two questions.
Yeah.
Where there is no continuity, there is what is called collusion and enmity.
Yeah.
So if different people see patients, doctors or nurses in their care, the expectation often is, the problem is I've got too little time, so somebody else will do it.
Yeah.
And that's a key feature of poor outcomes as a result.
Yeah.
And then with regard to patients' views of continuity, a study that was done way back in 2000, interviewing patients about their preferences, the vast majority, I think it was about 95% of patients, actually said that they would prefer to see the same person each time. Very few didn't.
Yeah.
And one of the reasons why they prefer it is because this is primary care driven, not disease focused. Because they have to tell the same story over and over and over, and eventually they give up, and as one of your quotes indicated, they prefer then to stop telling the story, just take the minutes
and go.
But I think the more important question is, why is it that we've known about the importance of continuity care for decades? And you quoted Pierre Chortel's he did his PhD in 1989, 1990. So we really have that. And it's in the charter.
Yes.
And we have all these wonderful policies and things that refer to continuity of care. And yet, we have largely failed, certainly in the public sector, to provide what you're referring to relational care.
Relational
continuity. Facility. And I think we know some of the answers to that, but I mean, it's a huge indictment on us all that we can't respect patients sufficiently to provide the continuity that the evidence, the research evidence, and we all agree is really important. Because we know that outcomes are improved health, reduced costs, even improves disparities between health disparities. So the evidence of that's been known for very long. So that's the question, I think, what do we do to shift the system? And so I'm interested to know whether any of the folks who interviewed the policymakers, the practitioners, what their views about putting this into place. What do they say in response to this is not possible?
Unfortunately, the policymakers that I spoke to, I must say I was a little bit, how should I say, I was concerned, for lack of a better term. I don't want to sound, I was concerned because they projected as if they have failed and still failing. You get what I'm saying? It's like we know what to do, but we are not doing them. And why is that? Ties up with what you're asking. So, like, for instance, Engel and Marx, these guys have drawn the association between poverty and TB for a long time. So the important question we should be asking also is about what is being done to alleviate poverty. Because we know the strong association between that and disease. Not only the cause of disease, but also retaining in care. That's where I'm coming from for social determinants of health. So these things have been explored over a century ago. And so that's why I said, okay, now we're talking about the link, the hospital, and there's a doctor in one of the primary healthcare centers who said, we do not provide safety nets for these patients at all. There's no safety net. So they talk about these things, but it seems as if no one is taking the exactly. I think that's where we still find ourselves, and probably 10 years after, or 20 years after this time, somebody's going to come do a similar research, and so we are asking ourselves now where we're going. Yes, thank you. Any other?
Can I just
yes.
want to get to
yes.
I mean, it is a mountain to climb to implement.
Yeah.
But at the Worcester CHC, the Stellenbosch family medicine department tried one thing which sadly failed because it wasn't in our consultation, I think. But what they did was they took all the practitioners in the centre, there were about 9 nurse practitioners and doctors, and they broke them down into teams, a really good team.
Yeah.
And so at least they were able to get continuity, patients were able to get continuity with a team.
Yeah.
Which increased the chances of seeing the same person.
Yeah.
And that's really doable. But I don't think we're not thinking hard enough, looking carefully to see what's out there that can phase in to provide better content. Probably not in our situation, it's not going to be possible to see the same practitioner at least 80% of the time. You can break to teams. The problem was there wasn't sufficient consultation, and then the nurses couldn't meet for tea together. And because they prefer to do that rather than have the breaks in their teams. I think that was one issue. But those things are overpowered.
Yeah. I think so too. I think so. Yeah, I think so too. It can be done. We just need to do it. Just need to do it. Okay, any other questions, concern? All right, thank you all. Thank you so much.
The register's up here for anyone who needs the.